Good evening, everyone. Thank you for taking the time this evening to join us for our first virtual discussion about Crohn's and colitis care at the University of Miami Health System. This virtual meeting is designed to be interactive with Dr. Maria Abreu and the selected attendees. Therefore, you will have the opportunity to chat both publicly or anonymously with Dr. Abreu and others during this meeting. We will be recording this presentation in case you would like a copy afterward. My name is Danny Yanez, and I am the Senior Director of Development for the Division of Medicine at the University of Miami Miller School of Medicine. Tonight, we have the pleasure of Dr. Abreu leading our discussion about the fantastic work happening each day in our fight against inflammatory bowel disease, also known as IBD. Dr. Abreu is a renowned gastroenterologist who specializes in IBD and is currently the director of the Crohn's and Colitis Center at the University of Miami Miller School of Medicine. Her most recent appointment is the chair of the International Organization for the Study of Inflammatory Bowel Disease and the recipient of a 2019 Sherman Prize by the Bruce and Cynthia Sherman Charitable Foundation that recognizes outstanding achievements in IBD. She completed her medical degree at the U, and her postdoctoral training included an internship and residency in medicine at the Brigham and Women's Hospital in Boston and a clinical and research fellowship in gastroenterology at UCLA. Dr. Abreu has more than 20 years of leadership experience in basic, translational, and clinical research and mentoring, and has authored more than 100 peer-reviewed articles, books, chapters, and reviews. We will be taking questions throughout the presentation. There is a chat function to submit your questions, which you can submit those to the name Q&A if you click chat on the bottom of your screen, as well as the opportunity to open it up for discussion after Dr. Abreu's talk. I hope you enjoy this evening's virtual event, and thank you again for joining us. I will turn it over to Dr. Abreu.
Hi, Danny. Hi, everybody. Martin Lindefeld, you scoundrel. Look at that it's a fake backdrop, right? Those aren't all bottles of wine.
It's fake.
I see Ellen, I don't see Taryn, but she's probably seeing patients. I'm so glad you guys made time for this. I hope not to bore you to tears because I can stop whenever you're getting bored. You can put that in the chat and then I can stop yapping. But Danny and I thought this would be a good idea because, because I love you guys and you're hand selected, so you're only on this call if I like you. And also because I've had to, obviously many people have been emailing, calling us about COVID and what to do, and everyone's worried and all that jazz. And so I thought maybe I could sort of tackle some high level things with you guys and also tell you some of the work that we've been doing, because unbelievably, I don't want to say paradoxically, I think anyone who's been invited on this call knows me well and knows that for better or worse, a lot of what I do, I have to go give presentations, I travel, I do all these things. And it is amazing to not travel. It's like, oh my God, all this extra time to think and to do and all that jazz. So I'm just gonna share some of the stuff that we've been doing as well. We've all been become very used to Zooming, but for those of you who have not been used to Zooming, that chat function that Danny keeps talking about is a great way to ask me questions, and I'll try to kind of keep an eye on it as well out of my peripheral vision. So all right, so this is COVID-19 101 although I kind of feel like everyone and their mother is an expert on COVID-19, right? So I'm going to talk about these various topics. And I think the meat of it, of course, is going to be how it relates to IBD, what you guys may be worried about, and I hope to leave time for you to ask me questions. This virus, this family gets its name of coronavirus because of these spike proteins, which make it very interesting to look at under electron microscopy. And hidden in these layers of actually fat or lipids that encapsulate this virus, the virus turns out to be made out of RNA that that may mean absolutely nothing to you. But in the lab, when we're trying to work on RNA, if you so much as spit in the tube, you've destroyed your entire sample. So RNA is exquisitely delicate. So therefore, nature has found a way to, in this case, protect it in such a way that the RNA is hidden until the moment that it's going to take advantage of us. Again, you probably know by now, this is I mean, you know, they were conspiracy theorists, but I wasn't one of them, because if you put animals together, you have one animal has one type of virus, and now another animal eats their poop and gets that virus, then by just the, you know, the rapid proliferation and mutation rate of a virus, one little thing could change, and now that virus can start replicating in that host and be able to be passed on, in this case, unfortunately, to us as humans. So I think the rest is history, how this happened to us. I think you know that the main route of transmission is via respiratory droplets, but I'm going to talk a little bit about how there's the still sort of theoretical possibility of fecal oral transmission. It's hard to prove that anybody got COVID that way, but it's theoretically possible since live particles have been found in stool. And I'll show you that the receptors for the virus are present also in the GI tract. Because this particular virus, this SARS-CoV-2, right, for the second of these, severe, right, acute respiratory syndrome viruses, because it's so similar to the first SARS and to MERS, some of what was already known about SARS, like the first wave of SARS, the ones that affected China, Asia primarily, was that you needed two ingredients in order for the virus to enter human cells. And that is, one of those things is this ACE2, which angiotensin converting enzyme is what it stands for, is required for there to be attachment of the virus to a cell. And then you need this TMPRSS2. It's an enzyme that is required, that's made by the human host, that cleaves this protein, this spike protein on the virus that allows entry into the cell for that to become engaged. So if you don't have this, or if the animal that's being infected doesn't have these two ingredients, the virus can't get into those cells. And this is actually just, I left both in, but this is just a prettier diagram of showing you that both ingredients are required for viral entry into the host. And then once they're inside what this virus needs is to be inside of the cell, because just that little sequence of RNA can't do very much. It's our cells or the host cells that are using that RNA and making copies and making copies and making copies of it and spitting them back out. We wouldn't be having this conversation, nor would we be stuck at home with nothing to do but to listen to me for some period of time, if this wasn't associated with a much higher rate of death than, say, the flu, which would be something that we would all, be comparing this against. And you can see that this is all of the stuff I'm going to show you is as hot off the press as we could make it. And you can see that we think in the United States there have been about 100,000 deaths from COVID, and with over 1 million people infected. Thankfully, as you well know, South Florida has been one of those intermediate risk places. Important for our discussion as we go forward and discuss how this impacts IBD, you can see that age has been an important determinant of who survives this. And as you know, that children are by and large protected, but as you get older, the risk of death increases substantially. And I won't show you this here, but other things like having other comorbidities, in particular being obese, is another major risk factor in mortality from this virus. I'm going to skip this slide, but as Danny said, we'll make all these available to you. There are a lot of words on this slide, but this is only to make the point that in previous studies, mostly studies, previous studies not done, just done in human samples, they have linked having higher levels of this ACE2 protein in tissues that have active inflammation. So that, you know, if you have inflammation, it might make these receptors go up in theory, but I'll show you what we found. This is a study that was published in Gastroenterology, which is our lead journal in the field of GI. And this study found that here they had samples. This is a Chinese study. This is a patient that was infected with the COVID-19. And this is a way of showing you that in fact, in the stomach and to a certain extent in the small intestine, they could find virus in the lining of the intestine. So this is just a schematic of what happens in IBD, and this is a representation of, if you will, the lining of the intestine. So here's the lining epithelial cells. Inside of that lining is, you know, all the bacteria that we coexist with, and we talk about bacteria, but of course there are viruses here, and there's also fungus here. In someone who has inflammatory bowel disease, these epithelial cells have the onslaught of damage created by immune cells that are releasing chemicals that have a toxic effect on that lining epithelial cell. And you can see some of the cell types that are kind of having a little war zone, and in a way the lining of the intestinal tract is caught in that maelstrom. Okay, and so we of course were interested in what effect might inflammation have on these receptors. And so when this was all happening and no one knew what exactly was going on with COVID-19 and all of the risks of, you know, patients were asking, what is my risk of developing, developing COVID-19? Am I at higher risk or not? We took advantage of the fact that we have a very large, biorepository of samples. Some of you who will remain nameless, but on this call are some of the numbers that we have here. As you know, we've asked for years, all of our patients, if they'd be willing to give blood and tissue to study what causes IBD. At last count, we have about 3,000 unique people in our biorepository. These are people like you that have altruistically allowed us to collect their clinical information, their DNA and blood, and if they had a colonoscopy, they allowed us to collect tissue, from the time of the colonoscopy. So we have like 15,000 samples of tissue, right? So what we did was we did kind of a more limited, we decided to have very, where to begin that story, like very specific samples that we were going to compare against completely normal people. And in this, what we found, and this was actually already published in the IBD journal. It's coming out, I guess, in the physical journal in June, but has been available online for a little bit. Is that you can see if on the y-axis, and hopefully all of you are able to see this, okay. On the y-axis is the expression of that gene that I told you was necessary for the virus to enter the cell. You can see that normal people compared to people who have active Crohn's disease, there's really almost no difference. If you look at the expression of that other receptor that cleaves that spike protein on the virus, again, really not a lot of difference between the two. We looked also at ulcerative colitis, not a lot of difference, and et cetera. And this is, just looking at inactive ulcerative colitis. So at least in principle, and this is looking at the intestine, it wouldn't predict that patients with Crohn's or ulcerative colitis are more susceptible for the virus to get in. Obviously, we're looking at the gut, but this is an important representation because the lungs aren't different in a person with Crohn's or, or UC. The gut is, if something's going to be different or discordant, it's going to be in the intestine of these patients. And so this makes that point as well, that if you, now in this case, what we did was we had already, for another project that we were working on, isolated specific immune cells from the intestine. These immune cells are cells that are important to fight off infection, right? They're they're termed CD11B, but these are cells that are important in the immune response. We had already taken from patients' biopsies, separated the tissue and isolated these cells. And then we had done this fancy thing where we looked at all the genes that are being expressed in those cells, like thousands, tens of thousands of genes. But we said to the computer, look, we're only interested right now. This week is COVID. It's all about COVID. Let's look just at these genes that seem to be important in the virus getting in. And if you do that, and you look at inflamed versus non-inflamed tissue, so in the black is not inflamed, in the gray is inflamed, you can see that actually people, even who had inflammation, if anything, you can see that inflammation makes it go down. Do you see that? Inflammation makes it go down. So in this case, it's one example that, in fact, inflammation, at least in principle, didn't make the tissue more susceptible to having a virus enter it if it was going to enter it. Okay. And then obviously these are our own patients, right? So they were on every kind of permutation of medication that you can imagine. And so we did a comparator of people who were on no medications compared to people that were on a medication, right? And so you can see people that had no medication actually had a slightly higher expression of this gene, so it's important for viral entry, compared to those patients that were on anti-TNF alone. So in other words, anti-TNF in this example would be protective of the virus getting in. You could see that here also with Entyvio is vedolizumab, ustekinumab is Stelara. And so you can see all the way across that the medicines we use actually keep the expression of the receptor down. Of course, we didn't go around doing lung biopsies on these patients. These were intestinal biopsies. Nevertheless, if there are any analogies to be drawn, since these are both mucosal surfaces, this would be relatively good news. But I'm going to show you more importantly, the clinical data from a registry that's being kept. Okay, so far, I don't see all of your faces, so I don't know if you're asleep, and since you're silenced, you could be snoring and I wouldn't know. Hopefully, let me see if Danny has, no, I don't think Danny has texted me to tell me everyone's asleep on the call yet. So I'm going to keep.
We're doing great. You're doing great.
Okay, all right, good. There's a sign of life. Okay, so let me tell you about this, because this is publicly available, and you could be Googling this whenever you're bored and have insomnia. These lovely guys, Michael Kappelman, Ryan Ungro had been my medical student when I was at Mount Sinai. He worked in my lab before going back to medical school, and now he's all grown up and a gastroenterologist, an IBDologist at Mount Sinai in New York. And they set up a registry, a database, the Secure IBD database, that is publicly available. You can Google it. And what it's meant to have is any doctor, anyone who's taking care of IBD patients who have documented COVID-19, not like they had symptoms, not that they have high risk, not that they stopped smelling. No. They had to have documented a positive test for COVID-19. That's the only way you get to be entered into this database. You don't put any patient names. You only put what medicines they were taking and what happened to them. Were they hospitalized? Did they need to be intubated? Did they pass away? Okay, you'll see that in a second. And in this database, look at we had our first conference call about this around here in March, and you can see the number of cases that have been reported to date. So people, and of course, it's probable that this is a combination of an increase in COVID overall, but also in people finding out about this database. And, you know, we've tried to get the word out all over the world, quite literally all over the world through our various organizations. For reasons that are not clear, more cases of Crohn's are being reported. Now, my sense is this is probably a reporting bias and not that actually more Crohn's patients are developing COVID-19 compared to ulcerative colitis, but I can't prove or disprove that. You can see here that as of, again, the very most recent cut of the data, that about 1/3 of these patients were hospitalized. But again, that for sure has to be a bias of the reporting, because, you know, if you're well, you know, especially in New York, many, I can't even imagine how many people were completely turned away. They weren't getting hospitalized unless you were unbelievably ill. And obviously those had very large populations of high risk, you know, high risk IBD populations that live in New York that were probably never tested even to enter into this database. So you can see the overall rates of all these things that have occurred. Then here it's ranked by what your risk is of developing. I'm going to just draw your attention for the purposes of the next couple of slides to the last column, maybe the last two columns. This is the percentage of people who are either in an ICU, on a ventilator, or who died. This is the percentage of people who died in this column. And if you just let your eyes run along it, you'll know that that's about the rate of death in the population at large, right? And this is stratified by whether the person had IBD but was well, whether they had mild symptoms, or they were severely, you know, had severely active IBD. Then this is by age. And here you can see again, you'll remember that graph I showed you of the overall population in the United States, and that's true actually all over the world. And again, I'll show you death, and you can see that really age is a very big driver of who dies from COVID-19, even in IBD, right? So that at least in this view of the world, it's not apparent that IBD worsens anything here. It looks like the same as the population at large. Comorbidities, you know, is the fancy word for, you know, did they have heart disease, they have lung disease, they have other things. And again, we know from COVID overall that the more things you have the matter with you, then the, you know, unfortunately, the higher the risk of a bad outcome. And then I think this is probably why a lot of you wanted to share some of your time with me this evening, which is by medication. And that's the most frequent question and calls that we're getting from our patients. So I'll make a couple of points on this slide. So as you can see here, along the left side of the table are the various medications that the investigators, you know, you had to pick from these medications people were on. For reasons that are not clear at all, medicines like mesalamine, you know, which is like Asacol, Lialda, sulfasalazine. Now here's the thing that I don't know, that they don't know, because they lump them together. I don't really know if, for example, this is all Europe and other parts of the world that are using still sulfasalazine, because, you know, of course, in the United States, we largely use the mesalamine, like the Asacols and Lialdas of the world, and not sulfasalazine. But their outcomes seem to be worse. And again, this I'm sure we can discuss that in the question and answer. People on steroids, you know, it's our mission to get people off steroids or really minimize steroid use, because here people on steroids didn't do as well. We know from the previous SARS outbreak, you know, not SARS-2, but SARS-1, that patients on steroids had more difficulty clearing the virus. You know, it doesn't let you clear the virus. Again, not surprising, because we all know that steroids suppress the immune system. But the majority of the patients in this database were on anti-TNF alone, right? Anti-TNF without any other medications. And that was the biggest chunk of people. And that chunk of people not only didn't seem to do worse, they actually seemed to do slightly better than the population at large. And I'll show you more data to support that. And then this is ustekinumab, Stelara. This is Stelara. Again, looks like it's slightly protective. This is Entyvio. And although this number looks higher than these, this is more like the general population. So Entyvio kind of looks more like the general population, and it's conceivable that anti-TNF and that, Remicade, Humira, Cimzia, Simponi, I think that would cover most of the people on this call. This JAK inhibitor is Xeljanz for the cognoscenti. And again, Xeljanz would be predicted, to inhibit a really good response to virus. And that also seems to be associated with a slightly worse issues. So this is looking at different reference populations. So let me take a step back and explain what this table represents. Remember this registry that I've just shown you takes it, is IBD patients being reported from all over the world. I showed you what their mortality was, but it's what do you compare that against, right? You need to compare that against some reference population, right? So you can compare it to other people the same age, and you can compare it within countries. So this is an attempt at looking at the three main countries, right? China, Italy, and the United States that have been affected by the COVID-19, and looked at the risk of death compared to this reference population in the United States. And you can see here that at least based on the data so far in the registry, the risk of death in our IBD patients is slightly higher because of certain other conditions. Again, compared to Italians and compared to the Chinese population, the risk of having higher rate of death is higher in the IBD patients than it is in these reference populations. They did this thing, which is like a multivariate analysis, is a way of taking into account a lot of different moving parts, is the way I would describe it. And I'll just show you a couple of things on this because otherwise it's, I, again, don't pretend to know that all of you are statisticians on this call. People that were on steroids, this is why we really want to get people off of steroids. The chances that something bad will happen if they're on steroids, which is ICU, ventilator, or death, is almost 7 times higher. So one of our priorities in the face of this COVID epidemic is getting our patients off of steroids. Being on TNF antagonists, you can see it didn't reach statistical significance, but it was slightly protective. It's 0.9, it's less than 1. Being overweight, right, BMI greater than 30, again, doubles the risk of having a bad outcome. Okay, I think that was just highlighting that and highlighting that. I apologize. So these are the conclusions of these investigators that have been working on this, that increasing age, having other medical issues, and being on steroids are really kind of the bad things that we need to be on the lookout for in our IBD patients. But TNF antagonists and the data we have so far on the Stelaras of the world seem to be not only safe, but possibly slightly better than safe. And for reasons that aren't exactly clear, people who are on mesalamine alone seem to have worse outcomes. And I may come back to that in a little bit later. I'm going to take it out of this mode for 1 second, guys, because I'd rather have more time for asking questions and less like graph after graph, okay? This is, I think that some of you on the call might be worried about mesalamine because, again, the Lyell, in theory, there's no obvious reason this should be this should increase the risk of people having something happen. But it could be reporting bias. That just means that maybe when people did get sick and they were on mesalamine, people were anxious to report it, whereas perhaps maybe when people were on mesalamine, doctors didn't even ask them to come in when they were sick. So you're only getting the really sick patients, and the people who called their doctor and said, I'm taking Lialda and I'm having a fever, they said, well, just don't bother me. You know, you can stay at home. And so there could be a reporting bias of that. It could also be that in a lot of patients are afraid to go on biologics, and sometimes they're on mesalamine because they don't want to try anything else, and yet they're unwell. Like, you know, they're sick and their IBD is not well managed. So that could be another reason why the 5-ASA is giving the signal. We're also planning to do some experiments in the lab to try to understand if that's just an artifact. Danny mentioned that in addition to, you know, my day job at UM, I got elected to be president, or it's called the chairperson, the chair chick, as I like to say, of this international organization for IBD. And we have, the organization is, I don't know, 60 years old, and probably has never had so many publications and so many, so much creativity in many, many decades. And we have been having weekly conference calls to develop guidance, because again, early on, nobody knew what doctors taking care of IBD patients didn't know what to do with the medications, didn't know if people should continue to come in to get their infusions, like all these very basic questions. And we've developed a lot of guidance about, you know, who should come in to get an infusion, and who needs to have endoscopies done and all that jazz. And it's just ioibd.org, and it's you know, a publicly available website, so you can go on it. We've partnered with the main GI society in the United States to also make the all the information that we've developed in IOIBD available to doctors more widely. And so we're proud of that. I'll tell you that a few very positive effects of this COVID-19 epidemic, if they're, you know, again, I hope not to hear that any of you have been very directly affected by this. But, you know, I take care of patients that often have to come very long distances, and including that I still am blessed to see some patients that I've cared for in other places where I've lived. And so I have always found it to be, to some extent, anachronistic to have all these people schlepping to see me in person, although normally I would love to hug and kiss everyone in person. For some things, obviously telemedicine can replace that. And we have been hampered because doctors don't have a lot of power, right? You know, we don't have strong lobbying groups. We don't have people to complain for us, like, say, the lawyers. I don't know, I'm sure there are some lawyers on this call. So therefore, we have not had very much clout. And then, of course, then this epidemic comes out, and all of a sudden we were able to dial on telemedicine. So this is a survey done of IBD doctors, like from around the world. And you can see here that this is before COVID-19, all, you know, for all intents and purposes, most of the visits were all done in person. You know, of course, we were having telephone calls with patients that parenthetically are not billable or had not been billable. And you can see that the blue bar is 0% of the doctors who are doing video consultation. Then COVID-19 comes, and you can see that now, you know, the in-person visits, you know, kind of plummet, right, during the peak of it. There are more telephone calls, but now all of a sudden people have started to do video consultations. So that changed dramatically after COVID-19. And most doctors believe that they're going to continue to do video consultations. I think at the moment, people are still trying to figure out, and institutions are still trying to figure out if insurance companies are continuing to reimburse it. Again, it makes no sense. You know, doctors want it, most importantly, patients want it, it makes sense to have a balance of video consultations, of telemedicine visits alongside regular visits. So I thought I would tell you other stuff that we're working on, because I think, you know, if you're on this call, you have been supportive of the research that we do and understand that taking care of patients is one dimension of what we do. But if we want to really make long-term changes and improvements in the health of patients who have IBD, we need to have better treatments, and we have to find a cure for these. And so, we're working on a variety of different things, and I wanted to share some of the stuff that we're working on, because it's, it's, again, I feel guilty saying it because, you know, people may be very directly affected by COVID, but for us, it's been an opportunity to kind of get a lot of projects, sent for publication and all that jazz during this time. I want to tell you that my lab runs the Germfree animal facility for the University of Miami. So this is what that means. We have mice, like the boy in the plastic bubble, but mice in plastic bubbles that are completely sterile. My technicians have to give them food and do everything through these ports. You see that? There are gloves inside these plastic sleeves so that they can manipulate the mice. It's a big to do, you know, sterilizing all the food and all the equipment and everything that goes into these cages to keep these mice completely germ-free. And so it's the only germ-free facility in South Florida. And this turns out to be critical. We can do things like take the stool or the micro, or biopsy samples from a patient with Crohn's or ulcerative colitis, and use that to populate that bacteria into mice that used to be germ-free, and study how a mouse that gets any of your gut bacteria on this call compared to someone else who doesn't have IBD, and see what's different about their immune response and what's different about any number of things going on. We've used this is a very important part of some of the research that we do that I don't think I'm going to show you tonight, but a big effort in my lab is to understand what makes people predisposed to developing cancer when they have ulcerative colitis and Crohn's disease, and teasing apart the relationship of the bacteria and what the bacteria are doing and what the immune system is doing that causes the cancer. We just had this accepted for this study, now changing gears to something more clinical. This study accepted into one of our best journals. I know Taryn is on the call, into CGH in clinical gastroenterology. And this is a study that we did that I think is going to be really a very landmark, a landmark study in our field. In this study, we had ulcerative colitis patients that were well, and we, of course, it's all voluntary. We tested 2 different diets. Each person went through both diets. So some people started with this low-fat diet, whereas some people started with what we termed SAD, for standard American diet. And the I is because we inadvertently made it healthier than a standard American diet. So we actually were giving people a healthier diet than their normal diet. And so each patient went through both rounds of the diet, 4 weeks of a low-fat diet, followed by 4 weeks of a high-fat diet, or vice versa. And the other critical piece of this study was that we felt strongly that if we wanted to have very clean data, we needed to feed people, because if they were left to their own devices, as we have been now during this COVID-19, people might go off the rails, and it's very hard to do a diet. If you look at this graph here, at this, this pie chart, we wanted people to eat only 10% of their calories from fat. I don't want to ask you what you've eaten today, but there's really almost no possibility that any of you on this call is only eating 10% of their calories from fat. So that was very hard, and that's why we had this diet catered. We found out a couple of really interesting things that included the fact that people eat like crap. They have ulcerative colitis, they're in remission, and look at, I'll just draw your attention over here to the servings of fruits and vegetables. At baseline, the servings of fruits and vegetables for these patients is almost nil. And so again, as I mentioned, inadvertently, they did better. They got more fruit and vegetables from each of the diets that we had them on. We found that we improved their quality of life in every dimension, that we improved their gut microbiome. And now we're excited because we've gotten a grant from the Helmsley Charitable Trust to do the same study in Crohn's disease. But what's cool about this study, and again, something that's never been done, is one arm of the study is going to not only provide catered meals to the patient, but to a significant other with whom they live, and will provide a psychological intervention to try to get people to change their behavior about diet. Because I think, I'm probably speaking to the converted, but it's very difficult to make lasting changes in diet. I'm going to skip some of this. We can talk about the fact that we've submitted an NIH grant to study cannabinoids in ulcerative colitis, and I'm sure some of you will have an opinion about that. And then we're also working with our bioengineering department to develop organs on a chip as a way to reproduce a mini intestine and be able to test drugs without always having to start with a human being. So I've been told by my minders that I'm like talking too long. So I'm gonna shut up and see now if, oh, there are no chat questions. How could that be?
They actually submitted those to me.
Oh, okay, because this is like the least shy group of people like ever. Let me see who else is on this call. Oh my God, it's Wendy, it's Ellen, it's Taryn. It's my Taryn. Let me see who else. Gail, I don't see the face. Oh, Darren. Okay. All right. So shoot.
So Dr. Brady, we actually had quite a few questions that were sent in through the chat. So first one is, should I keep my IBD appointments at this time?
Should you keep your IBD appointments at the time? Well, I'll tell you, only if they're with me. No, I'm kidding. I'm kidding. I'll answer that a couple of ways. I think many of you see me, I think, or I don't know of any business or doctor's office that isn't really trying to do everything possible for the patients not to get COVID from visiting them, or from their staff to get COVID from visiting them. This is, all I can tell you. Obviously, I work in what we call a hospital-based facility, which is like, what can I say, over the top. Like when I go into the building, I have to cross I don't know how many people that want to check my temperature, that want me to put on a mask, that want me to sterilize my hands, that want me to walk into the building. So the patients are all being pre-screened with a call the day before to find out if they're having a fever or having any symptoms, and discouraged from coming in to see us if they have any of these symptoms. And of course, we have the luxury that all of our staff are wearing, the PPE, masks and gloves and all that jazz. So I think, and the comment my patients have all made is that they really feel that they've been kept very safe. In particular, because just before being on this call, I was doing telemedicine visits. Some of the patients come in for infusions, because that was the other thing. The other kind of subplot to this is people coming in for infusions of their medication. So again, everyone's wearing, everyone's getting calls the day before. We have a list of screening questions. If you're positive for any of those, we discourage you from coming in. I'll knock wood and say that we haven't had any of our staff get sick or any of our patients get sick. And that we felt that in principle, many of you might know that one of the challenges that we've been facing is that insurance companies want patients to get their infusions done at home. It's much less expensive for them. But but I have the only one patient that I've had who converted to COVID-19. It could be, this might not be the exposure, but he had a nurse come, like a home health nurse, come to the house. And at least it was the beginning days of COVID. She didn't have masks. She didn't have gloves. She didn't have, they had not adopted all these things that we had in a larger health system. That might have changed dramatically. I'm not trying to cast aspersions on that. But remember, it's all these different home health companies. It's all these different nurses going to people's homes. They might have just come from someone's home who had COVID-19, and we don't know what kind of screening they're doing. So we felt in principle that even though you're coming to a facility, that at least we're trying to, screen and keep everyone as safe as possible. We have very specific guidelines, whereas we couldn't vouch for these home health infusion places. What else is on their minds, Danny?
Will I be able to have the COVID-19 vaccine when it's available?
That's a great question. I don't know who asked that, but I'm going to be so mad when flu season comes around and patients will tell me, Doc, I never get the flu shot because I never get the flu. Or every time I get the flu shot, I get sick from the flu shot. I will remind everyone that, and here we are in the midst of this pandemic and everyone wants to sign up to get a vaccine. So the reason I'm hesitating to answer the question is the presumption would be that the vaccine will be a recombinant vaccine, right? And that means that it's been made synthetically and it can't give anyone a viral infection. There are other types of vaccines where they take the virus and just make it weaker, but it's still a live virus. And there, I'd have to get back to you as the data becomes available about whether people whose immune systems are suppressed, whether it's a good idea for them to get it. I'm sure some of you have already been told by me that there are certain vaccines that you can't get that are live vaccines, like the MMR, for example, the measles, mumps, rubella. What else is there, Danny?
Before we open it up for folks to chime in, I did receive one that said, with most health systems under stricter budgets due to COVID-19 limiting procedures, how can patients both help philanthropically and as a volunteer?
Yeah, well, that's a lovely question. I think all of you are sensitive to the fact that, no different than any place else. I think this is going to be a tough time in our country, and we're sensitive to that. I think that we are, through your help, keeping employed our dietitian and our clinical psychologist, which is really important for patients. But we'd like to build on the strength of the things that we've already accomplished in terms of our diet intervention studies and some of these organs on a chip and studying new drugs for patients with IBD. And, obviously your support is essential to keeping the show on the road in spite of this unbelievable speed bump that we've hit in our society. But I'm sure we're gonna get through it. And like I said, I think that maybe it's given us an opportunity to be more thoughtful about how we move forward.
Does anyone want to unmute themselves and ask a question? Wendy?
Wendy.
Hi, wait a minute.
I can hear
me now?
Perfectly.
Okay. So I wanted to say that because of technical difficulties, it said I was locked out by the host, so I couldn't get in, and Danny, thank God, got me into this. So I missed the first 15 minutes trying to get in. Will this be recorded, and will I be able to see the beginning of that?
To your heart's content.
Yes and yes.
And how about any past ones that you've given that, let's say I didn't see? Danny, will you be able to send that out?
Well, this is actually the inaugural virtual event, but yes, I can definitely get you some of
By the way,
Thank you.
Isn't this amazing that we were together, a lot of us were together at Bonnie Sharp's place, right?
Right.
What would have happened a few weeks later? I mean, it was
Would have
it might have been
canceled.
just, yeah, it was just at the beginning. It could have, you know, it was before all this craziness. Like our, you know, absolutely by Bashert, we missed it by just nothing. By just nothing to have canceled it.
Dr. Brady, I had another come in through the chat. It said safety of stellar in pregnancy versus mesalamine. I'm not sure if I'm saying that right.
Yeah.
Both oral and rectal, especially in light of COVID-19.
For pregnancy, in pregnancy.
Mm-hmm.
Is that Taryn secretly sending those questions? I
cannot disclose.
I think you're still muted, you two scoundrels. You know, it's a great
not me.
question. It's not you.
It's not me.
This mesalamine data is, I don't know what to make of it. I really need to think that through. It doesn't fit my bias that mesalamine as a group of drugs should be very, very safe. We're going to try to study that in the lab. Actually, we're trying to, you know, we already grow intestinal cells in the lab, like stem cells and mini organoids in the lab. And and we have, like I said to you, this very, very big biorepository that we can try to tease some of this out. We also are trying to get inactivated COVID virus. And we have, I don't want to bore you, but obviously because we have such an enormous biorepository of samples, we have plenty of samples of people that were only on mesalamine, plenty of samples of people that were only on Stelara, plenty, you know, of samples of only on anti-TNF, and we're going to try to compare and see, did we miss some signal from the mesalamine and understand what's happening. We have it from colon biopsies and we have it also from blood. So we're going to try to figure that out. If you ask me, not COVID related, I think both of those drugs are very safe in pregnancy. Those are very safe in pregnancy medications, and I fundamentally believe that they're safe in even in the face of COVID. But I think there's something, you know, a lot of the world, there are a lot of people still on mesalamine that probably shouldn't be on it, that are probably not doing well from their IBD, and they just happen to be on it for unknown reasons. In addition, I'm not aware that they broke down who was on sulfasalazine. It might be, for all we know, the sulfasalazine, not really the acicols and Lialdas of the world. What else is on their minds?
Any indication that the Crohn's medicine may minimize the inflammatory response of the body to work on the virus?
Yeah, I think that's, you know, I think, again, all of us, because we're watching, you know, CNN, are all COVID-19 experts anyway, but you probably know that there are two phases, at least two phases. The first phase, that the virus infects you, that it's replicating and destroying some of the cells directly because of the virus. Then a second wave where your immune system starts attacking this virus. And sometimes that overshoots the mark and can cause so much inflammation that can be the reason that the people, you know, need to be intubated and die. And so already people have been repurposing some anti-cytokines, like anti-interleukin-6, for example, therapies to treat patients with COVID-19. Apparently, there's a syndrome in children who have developed COVID-19 that is like a Henoch-Scheinlein purpura. I'm really talking to Taryn when I say this, but where they develop like a severe kidney attack. The kidneys are being attacked immunologically, and their platelets are being attacked immunologically. And at least one kid at Mount Sinai in New York had a bad case of that, which is a manifestation of COVID, and had bad Crohn's with fistulas, and got a dose of Remicade, and like within hours turned around, no more fevers. His kidney function started improving. Like it was like a miracle had happened that he got it. So I think that in more than in theory, these anti-TNF therapies might inadvertently be muting this this sort of overzealous immune response to the virus in select people. But I'm aware, and I think it'll be very important to just collect as we go forward and testing becomes easier and the ability to check for antibodies against COVID becomes easier. I personally want to be checking all my patients for this because I think that we only know a tip of the iceberg, but presumably there are a lot of people who've been asymptomatic, who've converted, and we just never even knew that they had it. So I think that my hope is that the data will continue to be more and more reassuring.
Okay, we have about 5 minutes left. I did get another one that came through, or I guess this was asked earlier. Is it necessary to wipe down packages, mail, or newspapers, etc.?
Oh, you know, I don't, but I think that those aren't necessarily like surfaces that are high transmission surfaces. You know, it's the metal surfaces that the virus is able to survive for longer. And certainly imagine you'd have to have really unbelievably bad luck to have a postman spit enough virus on a package that you happen to touch it and then happen to, you know, wipe your eyes and all that jazz. So I actually don't believe in gloves. You know, when I see people out in the street with gloves, it kind of grosses me out. I think very frequent hand washing, making a mental note not to touch your eyes and not to touch your mouth. And I think most of us, except on this call, you know, are wearing masks outside. I think that that's probably plenty to keep people safe. And, you know, I think that the data I showed you is that you shouldn't panic, but I think you should take the precautions, probably precautions that are most linked to your age and to and anything else going on with you. You know, again, I'm looking at lots of very healthy people, healthy specimens, but that has more to do with that than they do with these medications that you're on. What I didn't highlight, and that, you know, Taryn Silverstein is an outstanding gastroenterologist, one of my favorite people, and she and I have had conversations about this. One of the groups that I worry about are people who are on multiple medications to treat their IBD. Again, you don't end up being on these medications for no reason. You're on these because you've been sick. But it's a time to really kind of think about who needs to be on what. What I find so humbling is we had, you know, all these conference calls and publications that came out of this IOIBD organization describing what we should do in this situation, in this situation, in this situation. Lovely. And then the next day I saw patients, and every patient was different. They almost never fit into this perfect little box. It's always like, yeah, but my brother was just diagnosed with COVID-19 and we just spent the weekend together. And, you know, it's like just when you thought you had figured it out, it's like, oh my God, are you kidding me? You know, yes, maybe you should hold that dose of Humira, you know, because we didn't know exactly what we should be recommending to people. So we're figuring this out together. Like I said, I think that this has allowed us to have this opportunity to be creative, to think about how we're not impervious, that even when we think we have things under control, something like this random viral event has completely transformed our society and the way we're going to live from this point onward. Not all for better, but I'm a glass half full kind of person, and I think that we should kind of look in our own lives how this could be a positive thing. And it's my hope that, you know, again, my lab hasn't stopped working since this occurred, because, you know, the show must go on. So I'm grateful for you guys to make time on a Tuesday night. I'm sure you have more interesting things to do, but I'm delighted that you made an hour for me and for us.
Wendy, did you have one last question?
Yeah, I had one last question. I'm in Maine. I actually flew on a plane with a shield, double mask, eye goggles, everything, poncho, it was crazy. and I made it, and I've been quarantining for 2 weeks, which I'm at the end of the quarantine and I'm fine. But now in this state, they were slower than Florida to open up. And now what they did was restaurants have tents in their parking lots, and people are going into these tents feeling that they're safe. And when you sort of drive by where restaurants are, there are so many people in these tents. And I didn't think it was safe, but I don't know. Can you kind of tell us about the other people who are socializing in their backyards with a bunch of people and they think they're staying 6 feet apart and they're having barbecues? What are you thinking is safe with all that?
Those are tricky questions. I think anything closed in is worse than anything outdoors. I think the virus, when you aerosolize, when you have aerosol droplets in an enclosed space, they linger in the air for longer. I like to solace myself that outside, of course, you know, there's wind, there are factors. When they've been testing how long these viruses last, come to Miami in like a 90-degree weather and you tell me how long that is going to last in the environment. So I think outside is better than anything enclosed. I think that barbecues, I don't know. I mean, how much spitting is going on in barbecues and how close you're going to get to people at you know, in a barbecue. But I do think that there's going to be, we're going to have another blip. I'm sure that as things start opening up, it's human nature. I think people are so, you know, really kind of frustrated and done with being enclosed that there will be some blip. Hopefully that won't be a very big blip, but I wouldn't be the first to be eating in a tent with a lot of people. And I would use your best judgment. I wouldn't go to a big barbecue party, but I'll share with you that we had a couple over for dinner the other night. It was like our first like couple that we hosted here for dinner. And quite frankly, I had intended and wanted to do it outside for the aforementioned reasons. But it was like, you know, this weekend you weren't here, but I mean, all of you maybe were here. It was extremely hot and muggy and rainy and like gross. And the Weather Channel said, I was checking it for every hour of the potential dinner party, 88 degrees feels like 100. So I said, okay, well, we're going to die of something. It's going to be either COVID or we're going to die of heat exhaustion. So I think you have to use your own judgment. And I think the rates in the Cape have been low, but I don't know that. My recollection is that the Cape has had very few cases. Cape Cod, right? You're on Cape Cod.
Thank you.
Yeah. All right, guys. All right. Well,
Dr. Brady, right before we close, someone asked if the International Organization for the Study of Inflammatory Bowel Disease, if they have patient resources as well.
We don't, it's not specifically directed at patients, but it's directed at physicians, but we think that, you know, the way that things are written are very user-friendly and like I said, it's publicly available. And it describes things like, you know, endoscopies, you know, what our precautions are in endoscopy and infusion centers and all that stuff. So you're welcome to, you know, it's not specifically targeted at patients, but it's not.
Perfect. Well, I'd like to thank everyone so much for joining us for our inaugural event. Really appreciate your time. Dr. Brave, if you want to give any final closing remarks.
We'll stay in virtual touch. We'll come up with something interesting to talk about next time. All right, my peeps. Mwah. Bye, everybody.
Thank you.
Thank you.
So much.
Thanks
Be
for
safe,
joining us.
everyone.